Yes, good afternoon. Welcome to our seminar series. Let me just say a few words to introduce myself and our seminar series, as well as our speaker for today. My name is Leonard Lee. I'm the director of the Institute for the Public Understanding of Risk at NUS. So I'm also a professor at NUS Business School. So just a few words about our institute. So this is an institute that focus on the study of risk perception and risk communication. And we are very pleased to co-organize these seminar series with our partners in Hong Kong University. This is with the Institute for Behavioral and Decision Science. So we're happy to bring to you a seminar these today, as well as another seminar in a week's time. So these two seminars relate to health and medical decision making, but we will have more seminars coming up on other topics as well. Right. Without further ado, let me just plunge right into introducing our speaker for today. It gives me great pleasure and honor to introduce Professor Jill Lei, who is a collaborator as well as a friend of mine for many years. So Jill is a professor of marketing as well as the head of the Department of Management and Marketing at the University of Melbourne. She specializes in research on consumer decision making in contexts such as food, financial, and medical decisions. And she has also taught in institutions around the world, including in the Netherlands, Canada, China, and Australia. Right. So Jill and I have known each other for many years, and so for some of you who are not familiar with this, so we actually co-organize an initiative called ECHO. So that is short for Empowering Consumers for Health Outcomes. So along with these initiative, there will be quite a number of activities that will be coming up. So please stay tuned to find out more about some of the activities as part of this initiative that we have attempted to start. So without further ado, I would like to welcome Jill to share more with us on her work. And her presentation title is The Impact of Socioeconomic Status on Patient Preference for Aggressive Treatment Options. And this is actually collaborative work with Jill as well as two other co-authors, which I shall leave Jill to introduce. Yeah, over to you, Jill.
Thank you, Leonard. Can everybody hear me well? All right, I'll start sharing my screen so then we can start looking at the screen. I'll see if I were to do the full screen. Can you see the full screen? Or should I move this away, right? So I should move this away.
It looks good, Joe. I think when we're doing it.
Okay. All right. I think great. Thank you very much, Leonard, for the introduction. It's my great pleasure to share with you our work in progress on this topic of SES impact on patients' preference for conservative or aggressive treatment options. As Leonard has introduced, this is a joint work. Maybe it's one of our first attempts to do interdisciplinary research between marketers and health economists. So the colleague here, Oh Yang, and he's a health economist from Melbourne Institute. That is a part of the Faculty of Business Economics in Melbourne University. My colleague, Fang Chi Lu, I believe, is also in the audience online. Leonard doesn't need an introduction. He has already, everybody knows Leonard. So that's our team. We started working on this maybe 2 or 3 years ago. I had started to think about the idea and really also grateful to the IPUR's seed fund to fund the studies that we conducted. I would have to say that this recent idea came from partly came from my personal experiences as well. My mother was a doctor, and we used to live in this hospital compound where the doctors live within the hospital. Um, And so your neighbors and your mother's friends, they're all doctors. They will talk about how they were treating patients and how patients were making certain decisions. So some of I think part of the idea came from those experiences as well. The other preamble I'd like to also talk about is this is not a typical CB or JCR type of a study, and we now truly realized that. So if you don't see the typical design of manipulating the IV and the moderation or mediation studies, please be patient with us. And this is something we try to do. I think what really keeps us going in this project is really our genuine interest in this research question, and we wanted to understand how consumers or patients make such decisions, and then hopefully we can shed some light on this decision-making process. Alrighty, I'll just get into it right now. So what we're trying to study is people's treatment preference. To give you a bit of a taste of what we try to study, so I'm using this as a prompt for you to think of this scenario that we try to study. I think many of you, so actually this is not a completely fictitious scenario. This was inspired by an experience shared from a previous colleague who has now moved to a different institution. So we all know that thyroid gland is a very a small but a critical organ. So it's a butterfly shaped organ in front of our neck. It regulates our body's system to convert food into energy. So it's a very important organ. So suppose, and not to imagine yourself, but this is the scenario. So suppose there is this is a situation where there are some benign nodules discovered in the thyroid gland, and there's some risk, although currently it's seemingly benign, but there are also risks that this would turn to something bad. So what kind of decision would a patient make? So these options we presented here, options A and B, are typical options that are presented to patients or consumers who are facing such a medical situation: active surveillance or minimum invasive thyroid surgery. So we also checked with doctors. I think in this case, we checked with a doctor in Singapore, also a doctor in China, just to make sure that the description and also the options presented are realistic. So what decision would you make if you are in this situation? I'm sure that you all maybe have some kind of thoughts already on your minds. So please keep that on your mind, and we'll proceed to next page. So this is kind of a typical scenario we study, wanting to understand how patients will make such decisions between a relatively more aggressive and a relatively more conservative treatment option. Of course, this is all in relative terms. All right. So some of you might be thinking, okay, why do we study patient preference? Shouldn't that be the decision of the doctor? Yes, in most cases that patients would discuss such preference or such decisions with the doctor, but we study patient preference for a couple of reasons. One is there's a growing practice in the medical field to incorporate patients in the decision-making process. And also, there isn't really hard evidence on which type of treatment option is more effective and it's going to really benefit the patients. In many cases, there aren't really clear evidence, and so in those cases, the doctors do want to ask patients for their preference. And we also then did a pilot study and interviewed 28 doctors across three countries or regions to ask whether doctors do they actually check patients for their treatment preferences for various conditions. So the evidence shows clearly that doctors actually do check patients for their preferences. So all of these are showing that this is not a question that we made up. It is a question that is in the real life. Then if you think about the patients as consumers of or special consumers for medical products and services, and as they consume similarly as they consume other products and services, they would also value and seek choice freedom. So given all of these, we think this question of understanding how patients choose or how they choose treatment options is a valid question. Now, the next question is, okay, given that we know that the patients do want to, it is a valid question to ask what patients would choose. Then the next question is, are patients feeling ready? Do they feel confident, or would they actually make such decisions themselves? So Edmund is a consultancy firm. They conduct these kind of trust barometer surveys each year on certain topics. So their survey on health and the trust in the last couple of years shows that people start to really equip themselves with the health knowledge that will allow them to feel confident to make a decision. For example, the 2025 report shows 35% of people, actually, if you can look at this results, in some age groups, it's over around 45% of people, they feel that by doing their own research, they feel they know as much as a doctor. And the 2024 report also shows more than 60% of people feel empowered to manage their health, including making health decisions. So this again shows not only the health system and the doctors feel that patients can express their preference. Patients themselves also feel that they've got the knowledge that's necessary for them to make such decisions. Then the next question is, now we've established that it is a real question, that to understand how patients make such decisions, and they also feel they can make such decisions. Then the question is, do they actually make good decisions? Do they make good decisions that eventually would benefit themselves? So that's the question. Now, again, looking at sharing with you some of the experiences I had when I grew up in China, I feel sometimes, of course, certain treatment preferences were shaped by certain contextual factors, including the tradition, the culture, or the medical environment. But there are certainly biases in this process. For example, the IV drips. When I was younger, I felt each time when there was a small medical or health issue, my mom, being my mom, of course, she would want to have the best treatment for me, and would always think about IV drips as the first option rather than some relatively less aggressive treatment options. If you look at this picture, you can see that in hospitals, this is not a uncommon thing in the past, but I think it's perhaps getting a bit better nowadays in China. But I would say that this picture is not uncommon even nowadays in China. So these kind of choices or preferences, or in maybe at the stage we haven't really established these are really due to the patient preferences. All we can say is these kind of treatments can cause a lot of problems, can cause a lot of issues, either financially for the patients themselves or for the overall health environment. So we are working on another project on AMR issue, antimicrobial resistance issue, which is caused by overuse of antibiotics. A lot of these IV drips are actually dripping antibiotics into the patient's body too. But overuse of such medications can cause a lot of problems. So this is where we started thinking about what is actually driving people's preference for relatively conservative or aggressive treatment options. So we know that a very important patient-relevant or related factor, the socioeconomic status or SES, has been shown to consistently affect the consumers or patients' health outcomes. And these outcomes obviously are driven by certain decisions that are made in the process of treating their health conditions. Some of these decisions, as we have established so far, can be influenced by patients themselves, their own thinking. So if this factor, SES, does affect health outcome, then it's really important for us to understand what is that behavior mechanism that drives these kind of outcomes. So in this research, we wanted to focus on how SES affects patient preference for aggressive versus conservative treatments. When we were doing this project, we had two RAs. One of them now has one of them has now become a practicing doctor. The other one, it is still medical school biomedicine student. So we had done a lot of background research in the medical journals to see whether this question that we're asking, for example, the choice between aggressive versus a conservative treatment options, is that quite common? So in other words, across the board, it is quite prevalent in many health conditions. There are these two types of treatment options available for patients to choose, which is indeed the case. So that again give us a lot of confidence that this is a valid and important question to examine. What we also wanted to emphasize here is we're looking for the psychological impact of SES on treatment preference. So this is over and beyond what the patient's physical condition requires. So this is a psychological impact, or if we want to call it a bias, that we wanted to study. We started looking at this question from the perspective of health conditions as a threat. So we used this protection motivation theory as the starting point, looking at if people are facing this kind of health threats, how do they evaluate, appraise these kind of threats, and then that would influence their behavior intention and actually the behavior. So the two important appraisals here, one is the threat itself, the other one is how well they can cope with the threat. So looking at the threat appraisal itself, our initial, maybe I could go back a little bit, our initial predictions. So when I say initial, that you perhaps will anticipate that there are some changes later on in terms of our current story. So the initial prediction was we predict low SES people or low SES would lead to a higher preference for aggressive treatments versus conservative treatment options. Why is that so? So we expect that people with lower SES, they often experience financial constraints. And this financial constraint make them feel the future is uncertain. So they have a higher sense of environmental uncertainty. And this sense of uncertainty makes the lower SES individuals to have a low tolerance of uncertainty. So they do not like uncertainties. And this sensitivity to uncertainty, or this intolerance of uncertainty, makes them perceive a lot of ambiguous situations as riskier. So for example, they might perceive the same health condition as riskier than higher SES people. And on the other hand, they also feel that they have less self-efficacy or fewer means to cope with the health threat. So this appraisal may come from their perceived lack of resources. When I emphasize perceived, I try to convey the message that they may or may not have less resources than high SES people when it comes to treating certain health conditions, especially, for example, in countries like Australia, there's a public health care system for certain health conditions, or actually for many health conditions, people have similar access to health resources. It's that perceived lack of resources, making them feel that they can't cope with such threats, either both presently or in the future. So these kind of appraisals would make them design something that's more definite, something that's more immediate, that can quickly resolve the health threats. So therefore, they can simplify the future decisions, and that also minimizes the future potential uncertainties. So we also expect that people have a lay belief that is aggressive options being more invasive. So this nature of being more invasive can make people feel that it offers a faster, more effective solution than the conservative options that may seem to be slow and ambiguous. So building on all of these arguments that I presented, so we have our key hypothesis that is we expect low SES people are more likely to prefer aggressive versus conservative treatment options than high SES people. So that was our starting point. Now, how did we examine this? We started by just doing a bit of sense checking of the lay belief that we think exists, and also the main effect that I presented just now. So this was a online panel study with prolific users from US, and we had 6 health conditions between subjects. And in each health condition presented 2 treatment options that's within subjects. So for participants, they saw a pair of these treatment options, then they choose. They also then rated each treatment option on the following attributes, including how effective it is, perceived effectiveness, costs, health risk, relative conservativeness or aggressiveness, invasiveness, and forcefulness. And then we also asked them then to indicate their relative preference between these treatment options. And then they also responded to questions measuring SES. We also measured this variable called medical maximizer or minimizer kind of tendency. This was from a medical journal, and they have shown that this kind of tendency could affect people's medical decisions. So what we found, okay, this just to show you the stimuli we used in the first study. So these were 6 health conditions. We described the condition. I'll show you one example on the next slide. And these were the different treatment options we used. So this is an example. You can see that we described the condition, exactly the same condition, and I presented the 2 treatment options. Again, these were developed by the RA who was a medical student and also now is practicing doctor. I also remember we also checked this with practicing doctors later on as well, just to make sure that they're valid and they're realistic descriptions of the health condition and the treatment options. So this was another one. And this is the initial results. So in this first study, we did find strong evidence of this lay belief that aggressive treatment options were perceived as faster, more effective, riskier, more invasive, more forceful. They're also more costly. And we found a marginally significant main effect, that is low SES people had a stronger preference for aggressive treatment. So it wasn't a definite answer, but we found a marginal effect there. So our next step was thinking, given that the nature of the topic, it will be quite difficult to observe anything consequential using experiments or the traditional CB research methods. So we then turned it into secondary data evidence. That's when we had this collaboration with the health economist, our colleague Oh Yang. So in the secondary data part, we were looking for a health condition which would usually present people with the 2 treatment options. One is relatively conservative, one is relatively aggressive. So my colleague Oh Yang has access to a lot of these health administrative data, And we went through a lot of these health conditions, and there were many of them were actually suitable, but then the data also has to be available. Eventually, we decided to use this health condition called acute myocardial infarction. So, or in short, is a heart attack caused by obstruction of blood supply in the coronary blood vessels to the heart. So this is the health condition. So with this health condition, there are usually two treatment options. One is PCI, the other one is a KABG. So PCI is a relatively more conservative option, and a CABG is relatively more aggressive. There are other options, but these two are the most common, and they also vary on the aggressiveness. And both options are covered by the Medicare system in Australia for Australian residents if they are admitted to the hospital. And we were only looking at patients who were admitted to the hospitals already. So in that sense, there aren't really differences in terms of affordability of the treatment options. Give you a bit of a background on the two treatment options. If you're not familiar with this, of course, when I was studying this, I wasn't familiar with this either. So I found this background helpful, this context helpful. So PCI, you can see that is a relatively conservative because when you have a blood vessel that is partially obstructed or blocked by plaques, then there's a thin wire that goes into the blood vessel, and the balloon will also be threaded into the area that has the blockage. And the balloon will be first inflated to really expand the area. And then a stent. A stent is a mesh, kind of usually is a metal mesh that is then threaded into the area. Then the balloon will be inflated, and then the mesh will also be expanded, and then the balloon will be deflated and removed. The mesh stays to make sure that the blood can go through the area. So that's basically the PCI process. So you can see that it's conservative because it's a minimum invasive surgery, just a day procedure, maybe a couple of hours, but this is not stable, right? So if the stent is further squeezed by the development of plaque, this needs to be redone. So this is not a permanent solution. On the other hand, CABG is to take blood vessels from other parts of the body and to build these bridges. You can see that if these two parts were blocked, then if you build these bridges to the heart directly, and that solves the problem more permanently. But of course, this is a major surgery, and it's a lot more, it's a lot riskier. So then we measured SES using the more kind of economic sense of measures. One is the geographic remoteness. The other one they call socioeconomic index for area. So this is the area level SES that includes a number of variables, including income, education, employment, and housing conditions. The other one is the patient status. So whether the patient has a private health insurance. This is because in Australia, people over a certain income level, if they don't buy a private health insurance, there's a medical levy. So it's better that they do buy a private health care insurance. So in the way that people's insurance status has a correlation with their SES or income level. So these were the typical indicators economists use when they examine how SES affects a certain indicators or certain behavior indicators. Then we look at the data. So we use the data sets from the Department of Health in Victoria. So this is the state the Melbourne University is in. We had data for 7 years from May 2004 to 2011. And we selected the people who were admitted to hospitals because of AMI and those people who did not have such admissions in the last 5 years. And so we also select people between age 35 and 90 because clinical evidence shows people younger than 35 or older than 90 have particular conditions that make their AMI condition more special than the normal AMI conditions. And in total, there were over 16,000 admissions in the hospital from 32 hospitals. Almost half of them were from private hospitals. The other half were from public hospitals. So this is just the demographics of the data set we had. And then the data, of course, was analyzed by our colleague. If you have questions about how the data was analyzed, I'm very happy to take the question back to O. We also did a couple of robustness checks. I think I want to point out to this one. So over 16,000 admissions, we used the matching method to find around 3,000 matched patients on these factors, such as their health condition, age, whether they survived after discharge, and so on, to make sure that the people who in the end chose either treatment option were very similar in their clinical conditions. So therefore, that's between these two groups of people, in the clinical sense, they could choose either option. So then it's more likely the difference was caused by something beyond their physical condition. And then the key results from the first indicator, we did find compared to patients in major cities, if this is indicator for higher SES, patients in the regional and rural areas were more likely to choose CABG. If you remember that this is the more aggressive treatment option. And then CEFA is the second indicator. It shows that in the lower CEFA increases the likelihood of receiving CABG, so the more aggressive treatment. However, CEFA was categorized into 5 different levels. We only found the significant difference between level 1 and level 2. With other levels, the direction is correct in terms of the effect, but it wasn't significant. And then we also found the same effects that aligns with our prediction for the private health insurance holders. So not having private health insurance increases the likelihood of receiving CABG. Just to briefly show you the results, you can see that these are just different robustness checks. So this is the result from remoteness, from CEFA, and from private health insurance owners. We also had one more indicator, although it is not often used as indicator of SES. There is some research showing whether people for example, in Australia, whether they're English speaking versus non-English speaking have some correlations with their income level. That also shows a consistent result. So that's kind of secondary data evidence, although not perfect, but supported our finding in the study one. There's some additional finding I wanted to briefly share with the audience here as well. So there is an index that hospitals use to calculate the severity. So here is actually the objective severity of the condition. So it is indicator of the complexity of the patient's medical condition by taking into account the various other conditions the patient also had during that medical episode. So what we found was the significant results happened more in the case when the patient was having a less severe AMI condition than when they had a more severe AMI condition, which in a way made a lot of sense to us. So when the patients, for example, are in a more severe condition, then the difference might not be there, because in that condition, either the doctors or the patient themselves might always prefer a more aggressive treatment to save life. So the difference is more likely to be manifested when the condition objectively is not as severe. So that leaves the room for some discretion to be made by the patient or the doctor, which one to choose. So that's when we observed more differences when the health condition, the focal health condition, AMI, wasn't as severe. So that made sense to us. In a way, it's quite interesting. So it's almost when the condition is severe that sometimes necessitates the aggressive treatment. But when the condition is not as severe, maybe they don't really need it, the severe, the aggressive treatment condition, aggressive treatment option. But low SES people actually are more likely to prefer aggressive treatment. Oh, of course, I'm making assumptions here. We do not know at this stage whether it's because of the patient preference or it's more the doctor's recommendations. This is secondary data. We only see the correlational evidence. Now we moved on to find more evidence for the potential explanations. So this, again, we went back to the prolific data of the panel to look for more evidence of the role of the perceived risk of the same health condition. If you remember from our arguments, we argue that low SES people, they are more intolerant of risk and they perceive the same or the more ambiguous situation as riskier. Therefore, they prefer more decisive, aggressive treatment preference. So here we wanted to first examine whether the perceived risk plays a role. So we had around 200 Australian residents, and we present this time 10 different health conditions. So this time the health conditions were shorter. So then we can examine more health conditions to have more generalizability of our findings. We measured the risk perception based on a scale developed by a researcher, and it was published in a journal specializes in risk studies. And these two, I just wanted to point out to the audience here. So these two items are typical measurements of risk perception, the severity and the likelihood of fatality. This one we added based on the context we're studying. The reason being that a lot of these typical measurements measure the risk perception of a situation in a static way, so the current situation. However, our reason is when people think about a potential treatment option for a health condition, they also assess the risk of the development pattern of this condition. So we felt this was a relevant item for the risk perception for our context. So we've developed this one, we added it to the overall measurement health condition. Across the conditions, the reliability was reasonable. And so again, the rest of the procedure was similar to the first study that we've presented before. So we found the main effects, again, using health condition as a fixed effect. Lower SES people were marginally more likely to prefer aggressive treatment than the higher SES people. We also found the mediation of the risk perception. So this was established. Now the next step was to find, okay, if now we find the mediation effect of the risk perception, can we further look into the mechanism that we propose? That is, lower SES people are more intolerant of the risk, so they're more risk avoidant. So we wanted to measure that. So next study, we looked at the mediating role of uncertainty avoidance. So they don't want to have uncertainty; they want to avoid further uncertainty, and so we again used the online panel. And this time we had a larger sample because we also wanted to rule out some of these potential confounds. For example, whether we present the treatment option choice first or we measure the risk perception first. If you recall, in the last study, we did measure this mediator first, which is not perhaps a typical approach. In a typical CB study, you would measure the mediator after the DV, which is the preference for the treatment option. We did this because we reason that this is a subjective risk perception. Once you first make people choose the treatment option, that will affect the perceived risk of the condition. So when we have a reason, this order measuring the mediator is better. That's how we measured the two variables, the median and the DV in study 3. However, we do recognize this becoming a potential confound. So we altered the sequence in study 4 just to see whether it makes a difference. We also had a different length of descriptions for health condition previous studies. We wanted to know whether that makes a difference, short and long description. This was a within subject manipulation. We presented the two treatment options in the randomized order. So that's why it's a much bigger sample. And we measured the uncertain avoidance, and this was a item we took from from a article from Journal of Anxiety Disorders, a very highly cited paper. I just checked before the seminar was having over 2,700 citations. So this concept measures people's tendency to avoid uncertainties, their intolerance of uncertainties. I'll show you briefly the items here. So people are asked to rate the extent to which this description is characteristic of themselves, such as unforeseen events upset me, it frustrates me not having all the information I need, and so on and so forth. So looking into these items, we felt this is what we were looking for to understand, to measure people's tendency of avoiding uncertainties, their tendency of not wanting to have uncertainties. So then we did the serial mediation, and it all worked out for the study we conducted. So the current SES leads to lower SES people have a higher tendency to avoid uncertainty, and that tendency increases the risk perception of the same health condition, and that leads to greater preference for aggressive treatment. You will also notice here that we now have a slightly different measure of the risk perception that includes the severity and the fatality and affect of worry. Reason being that these three are the more typical measurements of risk perception, and I think we were just a bit worried whether our own development of that development pattern item is going to cause issues in the review process. So we went back to this typical measurement of the risk perception. However, this time we did not find a main effect of SES on treatment preference, which got us a bit kind of puzzled. However, on the other hand, we also had some evidence this main effect was not strong, because you can see that from the past couple of studies, quite a few times this main effect was marginal, and then there in the secondary data evidence it didn't come out in all aspects. For example, some parts of the secondary data set it was not significant, although it was in the right direction. We start to wonder, but this serial mediation came out quite strongly, so we start to wonder perhaps there is a opposing force that is driving the effect from SES to the DV in opposite direction. Therefore, the main effect is a bit unstable. But this line of reasoning, this mechanism we try to show is there. And I also wanted to tell you, when we started the study, I had also an interview, actually interviews with 5 doctors from different departments, asking them questions about how patients make decisions and so on and so forth. So we went back to look at those interview results. One potential explanation here is it is possible that higher SES people may also at times prefer aggressive treatment, but for different reasons. So when we look into the transcripts of those interviews, one construct or one concept that came out was value of life. So in the way that higher SES people may perceive their life to be more valuable, therefore they might choose aggressive treatment given that it's considered as more effective. So we went on to explore this almost opposing force from SES to the DV and this role of value of life. And we found this construct of value of life from a medical journal, Journal of Aging Health. It measures the subjectively experienced worth of someone's life. So how one perceives the value of his or her life. And it just give you a sense of how the measurements were, how the measures were worded. It was a scale with more items, and we chose these ones that are most highly loaded on the construct, such as every day I have much to look forward to, life has meaning for me, I feel able to accomplish my goals. So it's really how people see the value, the meaning of their life. Then quickly, I know that we're running a bit short in time, so quickly, we in the next 4 studies run a series of studies to explore the value of life. So you can see that we had a sample from USA, from Australia, from UK. So Australia and the UK have a similar public healthcare system. USA is a bit different. So we wanted to see, regardless of healthcare system, whether the mediators we were exploring here would have similar effects. We explored mainly just 2 health conditions to keep this consistent so we can compare the results. So what we found is this. We found a very consistent parallel serial mediation. And this is regardless how we analyze the data, what variables we added control, which data set we use, which health condition we analyze as a focus health condition. So this dual mediation always shows up. What is interesting here is indeed there's 2 opposing forces here. So this was the initial mechanism that we had in mind. We showed also in our studies, this the opposing one. So higher SES people, they see themselves have a higher value of life that also increase the perceived risk of the health condition, and that also increased preference for aggressive treatment. So this may be the reason why the main effect is not stable. Thinking about the secondary data evidence where we did find a marginally or a significant main effect, that is a negative significant effect. Perhaps we are making guesses here. Perhaps the health condition we examined there, AMI, has made this pathway more salient. There's a lot more uncertainty involved in that health condition, made this pathway more salient. So that's where we're at the moment. I will spare you of the detailed statistics of the studies we run, 5, 6, 7, 8. And what are our next steps? So we wanted to further examine the 2 opposing forces here by kind of changing the strength of either pathway, by making the uncertain pathway stronger, or by making the value of life pathway stronger, to see further evidence that these are indeed 2 pathways that influence the impact of SES on people's preference for treatment. And then later on, and we wanted to then manipulate SES. This is perhaps more typical of a CV study where you manipulate IV. We haven't really got there yet. So what are we trying to achieve here in the final couple of minutes before I start to open for questions? I think first of all, we demonstrated a lay belief, that is the invasiveness of a treatment option is linked to people's perception about how effective this treatment option is. That is itself, I think, is interesting because a lot of treatment options, they're not necessarily invasive. For example, ultrasound treatment. It's not necessarily invasive, but can be quite risky for certain situations. So this invasiveness is perceived as more effective itself is an interesting finding in terms of people's lay belief. The more important finding is here, where we found SES on health conditions, the impact of SES on medical decisions are quite complex. It's not just economically driven, right? So for example, in Australian context or UK context, especially in our secondary data sets, the 2 health conditions or 2 treatment options were equally affordable because of the public healthcare system. So there's something more than the economic drive of SES, and this impact is over and beyond the people's physical needs. Specifically, SES seems to act as a cognitive switch that activates different decision-making processes. Low SES people, they prefer aggressive treatment option to avoid uncertainty. High SES people, they prefer such options because of a higher perceived value of life. So their life is somehow more valuable than others. But what can we use these findings for, given that the main effect seems to be quite unstable, but the two pathways are very stable? So we thought about this. This is our current thinking. That is, aggressive treatments is beneficial to in some situations. Of course, any treatment option has its benefit. The aggressive treatment, but however, there's a lot of evidence showing that overly aggressive treatment care is a problem, causes a lot of harm and a lot of damage, and is quite wasteful. And there's a survey showing a lot of physicians believe that at least around 15 to 30% of such care is unnecessary. And what is driving that unnecessary treatment is a lot of times is patient their own preference, their own demands. So can we solve this problem? There's research showing decision aids can actually reduce this preference for aggressive treatment, especially unnecessary ones, but only by 25% so far. So what we're trying to help here is now we understand that people with high or low SES people, they may, SES stated, they may prefer aggressive treatment for different reasons. So perhaps we can use this insight to help design more targeted and more effective interventions. For low SES people, we need to help them reduce their uncertainty. For high S people, we need to give them a more holistic view of value of life, help them trade off the benefit and risk and balance the two aspects of considerations. I know I took really long time to explain our studies, but open to questions. And if you have questions I can't answer in the session, happy to answer later on.
Thank you so much, Jill, for the wonderful talk. There are quite a few questions that have actually come in, and given that we only have about 5 minutes, so I'm going to try my best to moderate the Q&A as much as I can. Okay, so let me start with a question. Well, okay, so there are quite a lot of questions on what is going on. So essentially, right? So besides uncertainty avoidance, as well as value of life, could there be other mechanisms or explanations that could account for the effect? So here are some proposals or suggestions that are given by the participants. So one of which is the opportunity cost of time, right? So because, for example, we know that as the more aggressive treatments, they are more expensive, but they're also faster. So could there therefore be a trade-off between time and money, such that low SES people could actually have a higher opportunity cost of time, and could that explain the results? Yeah, Jill.
Thank you, Leonard. Yeah, so I might just quickly get to this question. I think on the one hand, if I may go back quickly to this mechanism that we proposed, that is the perception of self-efficacy, in the way that if you think about time and effort, there are also resources. So for low SES people, they perceive themselves have less resource to deal with the problem. So if they wanted to have faster, more decisive solutions, in the way it is to deal with this lack of resources. The resources could be anything that is required for them to deal with the condition. So that could be a part of this reasoning. But I think for low SES people, either it's because of time or effort or whatever resources is part of the reasoning why we think they may prefer aggressive treatment.
Thank you, Jill. Okay, just to further the discussion on mechanisms, so we have another member of the audience who also suggests a couple of other potential mechanisms, right? So one mechanism that the member of the audience proposed is To what extent might this be related to health literacy, such that low SES people might have lower health literacy, and to what extent could this also be related to the degree to which people have access to health services? Right. Your thoughts?
Yes, so health literacy we did measure, I think at least in one or two studies, and we did not find an impact of health literacy, but of course, which was self-reported health literacy. In terms of access to healthcare, I agree. I mean, some countries, people would have different access to healthcare. For example, in US, that is why we also did the study in UK, in AU, where health care access is less kind of different in different SES groups, especially in the secondary data set. We made sure those people were admitted to hospitals, and when they are admitted to the hospital, the access to those two treatment options were the same. There was no difference in access to healthcare.
Thanks, Jill. Okay, so a couple of other questions pertain to the scope of the effect, or in other words, the extent to which there could be nuances in the effect and potential moderators. So one question, for example, ask to what extent would the effect depend on the extent to which people rely on extended family support, right? And could that actually also play a role in the amount of perceived threat or the risk perception? And a related question is also whether in our results or in our data, do we observe low SES people having greater learned helplessness and having a more fatalistic view of their health status? Yeah.
Yes, I think loss can happen kind of between the current SES and the two mediators here. For example, when low SES people have family support, then I believe they feel more capable of dealing with the health condition, and that the tolerance level of risk might be a bit different, which will affect their risk perception and also preference for treatment. So I think a lot can happen between our key variable of interest ICS and the two um, mediators or mechanisms here. Eventually, it is about how people assess their capability or their ability to cope with such a threat, which will affect how they assess how they prefer one treatment option over the other. Yes, I agree. I think people might be less verse of uncertainties when they feel that something's got their back. Some people are, they've got someone to get to support them, and someone's supporting them. Yeah.
Okay, so in the interest of time, I'm just going to take one more question, the final question. So this comes from one of our members of the audience. So essentially, this particular member of the audience is interested to understand more about the relationship between our two mediators, value of life and uncertainty avoidance, right? To what extent are they similar constructs, or to what extent are they different constructs? And so this question arises because in this, for some research that was done by these member of the audience, they have observed that in their own qualitative study of women who undergo mastectomy, yeah, so I just make sure that I don't like butcher the name after breast cancer, those two concepts can actually be quite similar, right? So in other words, the more a person value one's life, the more the person might want to avoid uncertainty. Yeah. Uh,
Yes.
so in short, to what extent do you think these two concepts are related or similar? Yeah.
I think conceptually they are distinct concepts. One is about how much one values his or her life to perceive the worth of the life. The other one is this intolerance of uncertainty. So conceptually, I feel they are different, but whether it is possible that values the life highly, that leads to more avoidance of uncertainty, or the other way around, it is possible. In the analysis, we also analyzed the even longer chain of serial mediation, but that's not stable and it doesn't always show up, and it's not as strong as these two main chains of mediation.
Thank you so much, Jill. Okay, so we're completely out of time. So please join me again in thanking Jill for her wonderful presentation, as well as taking all the questions from the audience. Thank you, Jill. Yeah.
Thank you, Leonard. Thank you, everybody.
And so thank you so much for attending today's webinar, and we look forward to seeing you again next Wednesday, when we come back for another insightful talk on health and medical decision making. Yeah. See everyone next week.
Thank you.